Our next talk is Dr. Mark Emberton. He's going to tell us if we have one less thing to worry about with non-imageable prostate cancer.
That seems the opposite talk of Dr. Abreu's talk just now, Dr. Emberton.
So thank you. Great privilege to be here. So I think we should probably remind ourselves what it is that we're discussing. So the visible phenotype of any tumor in any solid organ is obviously a tumor that has overcome the immune system. It's had genetic mutations that are pro-proliferative. It has survived. It's picked up a blood supply. And our discriminant test, whether it be PET or ultrasound or MRI, is able to identify that tumor with over 100 million cells. And I suppose the question we have to ask ourselves, is that phenotypic expression so different from the non-visible tumor, which obviously we cannot see? Its fate is indeterminate, and we cannot monitor it, and how we apply that to our kind of clinical decision-making. Just so there's absolutely no doubt on where I stand on this, is should we be worried about non-visible prostate cancer? My answer is no. I could sit down now, actually, if you like. But actually, this is quite a big story. I think you had a lot of it yesterday from Laurie. I haven't seen the slides, so you'll see there'll be some repetition. But this needs about an hour to go through carefully. So what I want to do is just illustrate the areas where we're getting the information to inform this kind of new area of thinking. And I think the principal objection that I have is Lord Kelvin's objection to doing science when you can't measure the thing that you are observing. And for me, that's the big problem with subclinical disease. We just don't know whether it still exists, whether it's mutated into something, whether it's achieved a mutation that is not selective for survival. We cannot monitor it. When we rebiopsy, we don't know if we're biopsying the same thing or another lesion. And so the science of non-visible disease is very, very poor. And I would suggest that it makes actually understanding the biology almost impossible. And just look around. We don't do this for any other solid organ cancer, which are much, much more lethal than prostate cancer. So we have to really ask ourselves, and justify it if we're not doing it for lung and brain and liver and kidney. And I think my kind of third objection is that nobody really cares anyway. I mean, if people truly believed that subclinical disease was lethal, then they would go after it, and nobody does. People use, 12-core truss biopsy, and from PROMISE we know that has a sensitivity of 48% to detect clinically significant disease. That's inconsistent. If you really cared about this, you would go after it with 5mm template sampling, which would give you a 90 to 95% chance of ruling out clinically significant disease by any of the criteria, but nobody does that. And the nobody cares bit goes into this kind of modern approach to disease. This is illustrative, and the details don't matter, but this is yet another kind of feature extraction exercise to try and predict what's in the prostate. This was published yesterday, just to kind of give you some contemporary. I had a lot of time on the plane yesterday. And what's interesting, they got clinical inputs and radiological inputs, MRI and ultrasound. This was a contrast ultrasound. And the important thing here is that there was no value at all into the model from anywhere other than the lesion, whether that lesion be defined by ultrasound or indeed MRI. So the science of feature extraction, the modern AI approach, doesn't care either about non-visible disease. And an anecdote, so I keep presenting this chap, and I collect these individuals. And this is a chap I met in 2015. Somebody else had biopsied him 2mm of Gleason, 4+3 right base, and he's still going strong, and no evidence of disease whatsoever. And I suppose, and I've refreshed it up to 2023, I haven't managed to refresh it this year yet. So I suppose the really interesting question is, what has happened to that Gleason 4+3? It was confirmed, the slides were reviewed, and the slides were his. That 4+3 may no longer exist. At least there's no evidence of it some 7 years later. And we've seen this already, and I'm sure Laurie showed you yesterday, but and these are bad scans. We've heard that already, right? So if you did this with good scans, you would increase the threshold. And it's that bottom left slide that is critical. So these are men who had prostatectomy, and it does show this, that your MRI was negative. That MRI doesn't have to be very good. there was zero risk of dying of prostate cancer, which I think tells us that invisible disease or MRI-negative disease in these 1,500 cases is not a metastatic phenotype. If it were, there would be some deaths in this group. And this should provide a huge amount of reassurance for us, because this is 15-year data on 1,500 men. We also know, and this is our active surveillance data led by Caroline Moore, that lesions progress. You would expect them to. They've already overcome the immune system, they've got a new phenotype, they progress, it's just a case of when. And invisible disease takes a lot longer to progress and may not even progress to visible disease in the long term. Where else can we look? So if you look at the radiation recurrences, where do these recurrences occur? Not in the areas of invisible disease. Almost all of them occur into or next to the index lesion that was seen pre-radiotherapy. What about when we get discordant results? So when you do a Stockholm 3 and it's positive and your MRI is negative, what trumps what? And surprise, surprise, it's the MRI that trumps the Stockholm 3 positive. This was published last year. And that if your MRI is negative, you can omit the biopsy, these investigators have said, because the yield is so very, very low. And of course now we're beginning to, and I accept the studies are small, but they're just about to get much bigger. Our reimagined study has 1,000 men, deeply phenotyped, and we'll be analyzing the genetics on all those individuals. All those men have lesions, not all those lesions are cancer. I won't dwell on this one, but maybe just a little bit on this Finnish study. Again, very small and a slightly unusual cohort in that they derived the invisible disease from men who had prostatectomy for visible disease, right? So this is invisible disease in a prostate that's already developed a visible cancer. And so this will be a lot higher risk than somebody presenting for the first time with a normal MRI. But I think there's some really interesting features here. And the kind of hierarchical clustering, I think, is starting to give us a little bit of a story. So it would suggest, and these are the visible cancers that you can see there, are quite distinct from a phylogenetic perspective to the invisible cancers, which are there. So this would suggest that visible cancers are born bad and don't become bad from invisible cancers. These are distinct hierarchical clusters, quite different. Again, very small study, this needs to be repeated, but it's starting to give us some insight into the underlying biology that we're dealing with two completely different phenotypes. And when we look at the gene expression in this Finnish study, and I hope you can see this, but if you can't, you're sitting at the back, the invisible expression looks very, very much like the benign expression that was taken from TURP specimens as the best source of kind of benign tissue. Quite distinct from the gene expression you see in the visible tumors. And if you look for the genes that are associated with prostate cancer mortality, with the visible versus invisible, the bad ones that are associated with progression and death are hugely overexpressed. There are two that are not associated with death that you see in visible lesions, and they're seen there. And what we're seeing is, proliferation-related pathways, inflammatory pathways, and transcription regulation pathways disrupted in the visible lesions. And what's starting to emerge, again, a very recent study, and this is nearly my last slide, is that it's not just a binary thing, visibility or not, is that a range of expression of visibility may also be important. And these investigators looked at ADC expression, low, intermediate, and high, and that was associated with the kind of 5-year biochemical recurrence after radical prostatectomy. So if you had a low ADC, i.e. a very visible tumor, you had a much higher rate of progression over time. So I think, Chairman, I think I was posed the wrong question. So for me, and I think the evidence is starting to accumulate, and a lot of us are starting to believe this, that actually the thing is conspicuity, that the pathology is kind of secondary to that, largely because deriving the pathological status is prone to so much error. And the conspicuity doesn't seem to matter. It's whether it's ultrasound, MRI, or PET that is giving us this new and distinct phenotype that is linked to both progression and prostate cancer death. So I think there's very little evidence to suggest that non-visible prostate cancer carries any risk. As such, this is provocative for the discussion. A diagnosis of non-visible prostate cancer might be regarded as a kind of medical error. It doesn't serve the patient to find it, and that might make us resist from biopsy, and that risk stratification pathways need to concentrate on the lesions, whether they be derived from MRI, PSMA PET, or indeed ultrasound. Thank you very much.
Thank you. Stay up here. Andre, we're going to have a moment for a few questions. Just why we're here, why Andre's coming up, the recurrence after radiation therapy is so consistent or so common in the MRI visible tumor. Does radiation really work?
I mean,
it's like, let's get the question, sorry.
Rhetorical.
So I may ask the same question I asked Lori yesterday, because what I'm going to be talking about in a bit is trying to assess margins intraoperatively during focal. So is there a difference between invisible disease that sits within the halo of a visible lesion and invisible disease that's true multifocality or elsewhere in the gland? Because, you know, your initial slide that shows the mortality rates after MRI visible disease, as you pointed out, that's a very different group, right? Somebody who comes in, has a radical prostatectomy, but has a completely normal MRI. That's different in visible disease than somebody who's got a big lesion on one side and multifocality on the other side that we don't see. The Finnish study was interesting, but it doesn't really talk about outcomes. So the question is, do you distinguish between those entities, invisible disease within the shadow of a visible lesion?
So I think there's still huge uncertainty about what the non-visible components of the prostate are. Obviously, you would think that if somebody's had a visible lesion and a clinically significant disease on the left-hand side of the prostate, that they would be at greater propensity for developing another one on the other side of the prostate than somebody who hasn't had that done. And those, I mean, it's early days yet, but understanding, and within Reimagine, this is one of the questions we want to address. So it's the genetics of the prostate and the kind of precancerous changes in the prostate that we're seeking to evaluate to see if second primaries, this is out of field, so I'm not really answering your question. In field, I think the prostate's like every other cancer, you know, melanoma, glioblastoma, hepatoma, all need to be treated with a margin. The risk is in the tumor. There'll be a lot of different subtypes within the tumor. Once it's established that and evaded the immune system, picked up a blood supply, you've got to get it all. So, and I think we could argue about what is a reasonable margin in focal therapy, but it's somewhere between 5 and 10 millimeters, I think.
Just to be provocative, if you do perilesional biopsies and then it shows grade group 1, forget it, it's not cancer, so you're all good. So even more on this discussion. So.
Dr. Turkbay?
Yes, so good morning. I'm a radiologist and I'm Pirates committee member, and my question or comment is to Andre. So you mentioned MR invisible, Pirates 2 lesions are MR invisible, and I disagree with that. Pirates 2 lesions cannot be counted as MR invisible. They are lesions, we give score to them. And as a clinician, you need to utilize all the information, and then you need to make a decision. And if you find the case risky, you got to biopsy that. I'm not saying PIRES is perfect or MRI is perfect. Prostate is the most difficult organ to image. That's why we have been discussing this for the last 17 years with art. Okay? So human is not enough. I agree with that. So we need to bring some strong computer vision. PSMA will not be enough. I have bad news for you. So overall, the topic is very difficult. The imaging is very difficult. And you need to approach, you know, the focal therapy a little bit cautious in presence of that. So there are lots of still unknowns and unexplored stuff. And most of the literature, as you mentioned, is retrospective. So it is valuable academically, but clinical translation is, you know, not currently possible. Thank you.
Thank you. Dr. Klotz, last question or comment?
Yeah, those were two great and both very convincing talks. But it seems to me, one is entitled to one's opinions, but not to one's own facts. And it seems to me one of the disparities that there's not agreement about between the two of you is the frequency of the kind of case, Mark, you presented of high-grade cancer of significant volume that is invisible. Because, and I agree with your basic point, Mark, very much. But if it turns out, as Andre is suggesting, that grade group 3 and higher, large invasive cancers involving seminal vesicle and so on, like clearly serious cancers, are frequently invisible, the whole thing has a problem. My impression is that those are uncommon, very uncommon. Those are the outliers. Those should not drive biopsies on hundreds of thousands of men to find the rare outliers. So I wonder if we can get some consensus about that particular fact. Andre, in your opinion, these are common.
Very, very good questions, and thank you for the questions, Dr. Klotz. They are not common. I would estimate that about 10% of invisible prostate cancers behave like that. But the problem is not this. The problem is if we drive this field the way it's being proposed, we will forget about everything and focus only on MRI. That's the problem. The problem is not to show if it's visible or invisible. The problem is you get your negative MRI, you get your ticket, you're safe, get out of here, we are done. We are urologists. Urologists don't do DRE, don't do PSA, don't do anything anymore. It's just MRI and we're done. We have become now orthopedics. There is a fracture, I fix. There is no fracture, you're good. No, bye.
I think we can be pretty relaxed. Laurie, you and I have had this discussion often. Every time I see somebody with metastatic disease, which is rare now, I go straight for the MRI and to see what was there. And there's always a socking great tumor that you can see from across the room. I've yet to find, and I know we're both looking for it, somebody who's metastasized with invisible disease. I've yet to find it, and nobody sent me a case as yet. I think the Memorial Sloan Kettering data, rubbish MRIs, apologies, but they're...
Thank you, because I got in trouble for saying that once.
Allows us to be pretty relaxed about this.
I think in matter of time we should proceed, so thank you very much, you both.
Just respond to Dr. Tukby. Sorry, we have 2 minutes for our session, it's still there. We should respectfully respond to his points. Thank you so much for his authority in the field. Everybody knows him. Probably the most radiologists published in this field on the prostate cancer. And him himself is saying that now not only PARITS 3, but PARITS 2 should be considered visible. What do you say?
Oh, no. Well, there are threshold issues, and we don't use PIRADS, we use a Likert scoring system. 1s and 2s are normal, we discharge them. PIRADS 3s, we use PSA density to help discriminate, or PSMA PET, and increasingly a kind of risk calculator. But increasingly, we're trying to avoid unnecessary biopsies. And as people will know, we're developing lots of sequences that are tuned to try and discriminate between, to help us with PIRADS 3.
I agree with both of you, but all we need to do is tailor the case. Do not just apply a blanket, not just chocolate vanilla ice cream. Tailor the case, please. If we say PIRADS 2, do not ignore it. Just look at the family history and other stuff, please. Because, at the end of the day, you say, we report something, you say negative, and something bad comes out, and radiology is on the spot at the end of the day. So we got to tailor.
Just to take Dr. Emberton's data, Barris and our data, a PIRADS 2 lesion or negative, there's a less than 5% chance of clinically significant prostate cancer typically. But it's not 0. So that's what Barris is pointing out. And PIRADS is a fictitious scale that we layered on top of our expertise to be able to communicate with one another. So the clinical variables are still important.
So I'm going to interrupt you because we're locked into this thing that clinical significance is a histological kind of concept. We may be wrong. And it may be that actually it's visibility that matters. right? And that this, to
But
drive
visibility is a
everything back to-
volume-based phenomenon because you're looking at your 100 million cells to
Yeah.
make sure you're able to visualize it. So there's the biology of that disease is playing the role too.
They all progress. They all have pattern 4. They're all invasive. We know the underlying genetics now. It's visibility that carries the risk. The underlying Gleason score is of diminishing importance.
So yeah, I struggle.
What you're saying is that you get Gleason 9 with a negative MRI, doesn't matter. Is that correct?
Yeah.
Okay.
Just like a negative brain scan, negative mammogram, negative.
But what's negative, and that's our other problem.
Yeah.
And
A negative means invisible so far.
no. But negative doesn't. A negative from one institution clearly is not a negative from a high-end institution.
No. It doesn't matter the institution so much. If you get very high level, it still is human being, still is radiologist, they will assess the MRI potentially suboptimal.
Could I make one comment?
Yeah.
I think what you're doing, Mark, over in England, where you're looking at a whole genome sequence, is going to put away this conversation completely, because it's not going to be histology, it's not going to be imaging, it's going to be the genomics. And you remember when Hashamed did his New England Journal of Medicine article on the index lesion, there was a subsequent series of small papers showing that sometimes it wasn't the index lesion that metastasized, proven. And there were small numbers, but I presume that it's the genomics of the actual individual cells that metastasize that are going to tell us what the significance of the cancer is. So once we have that down pat, and I presume your 1,000 patients will help us work on that, there'll be a small number with genomic instability which metastasize, which aren't visible.
So I think that's wrong. The Hafner paper that you're alluding to was a T4 tumor that was occupying the whole prostate, and one case, and I think it's very, very dubious, arguments. But that's another story.